Well, morning, everybody. Um, Welcome to Grand Rounds. Just a couple of announcements. First of all, congratulations to all the members of the faculty and students and trainees who ran last week in the Derby run. I know there were 3 from my division, so that was pretty impressive. Um, Secondly, I wanted to announce that the former dean of the medical school, Ed Halpern, will be in town to give a lecture at the Filson Club Monday, May the 20th at noon. His lecture is going to be about the rise and fall of American Jewish hospitals, which I think is quite apropos to what's happening here now. Apparently, the Filson Club is going to have a huge exhibit on that topic, and he was asked to be a speaker, I guess, to set it off. So that's May the 20th, so it's a week from Monday. I don't have any other announcements. So at this time, I will ask Dr. Julio Ramirez, the Chief of the Infectious Disease Division, to introduce our speaker today.
Thank you. Good morning. It's a pleasure for me to introduce Dr. Anupama Raghuram. Anu has joined the ID division, the Department of Medicine, in 2012. After completing her fellowship in infectious diseases at Rochester University, she's very much involved in the care of HIV patients. She's the director of our Ryan-White grant. She's the director of our 550 clinics. She's very, very, very involved in patient care, in teaching. She's the associate director of our fellowship training program. She's also involved in research, primarily in the area of HIV disease. And today she's going to give us an overview of pre-exposure prophylaxis to prevent HIV infection. Anu?
Good morning, everybody. It's a pleasure to be here. And today we will be talking about HIV pre-exposure prophylaxis, not to be confused with post-exposure prophylaxis. So this is treatment for HIV negative patients who are at risk of acquiring HIV infection. So our objectives for today are going to be to review the HIV global burden of disease and transmission. We're going to understand the rationale for HIV PrEP, and we will review the efficacy and indications of this treatment. And we'll also go into analyzing the initial barriers in prescribing HIV PrEP for providers. And we will finally discuss our local experience in the 550 PrEP clinic. So we're going to start with a case. So this is Joe. He's going on vacation, and he asks about PrEP. So Joe is 28 years old. He doesn't have any significant medical history. He's not on any medications. He plans to be away in Southeast Asia for about 2 weeks. He is bisexual, and he does endorse inconsistent condom use. He's planning to have a good time when he goes on his trip, okay? And he wants to know if HIV PrEP is prior to travel or during travel is indicated for him. So what we'll do is we'll go through the talk, and at the end we're going to revisit this case, and hopefully that would have helped guide you as to how to approach this particular case. So let's start with HIV global burden and transmission. So I'm going to throw out a question to the audience. How many people do you think are estimated to be living with HIV worldwide? So this is low tech, so I'll do raise hands. 1 million, anybody for 1 million? Anybody for 10? 37? Okay, good. And billion. So the majority got this one right. So it's 37 million approximate. This is the worldwide distribution. You can see here almost 37 million. This data lags behind by a bit, but even 2017 data was pretty close to 37 million. And you can see highest burden of disease in Africa. You can see among the Americas, we have about 3.5 million cases. whereas in Africa you have 25 million cases. These are the amount of deaths by HIV, so still about 1 million deaths today. And this is now the distribution in the United States. So the darker the blue, the higher the burden of disease. So you can see the southern states, definitely a darker blue here. For us, we're in the lighter blue area, but that is the distribution in the US. And there's about 1.2 million cases in the US. Now, if we focus on Kentucky, this is the amount of cases as of 2016 in Kentucky. And here we are. The darker the red, the higher number of cases. So we do have more cases in Jefferson County. And if we look at distribution per risk of transmission category in the United States, you can see that male-to-male sexual contact comprises the large majority of the new HIV diagnosis in the United States. And if you look at Kentucky, that still holds true. You have 58% of males who have sex with males, accounting for the new HIV diagnoses in Kentucky. Now, if you look at in the US, if you look per race and ethnicity, you will see that African Americans account for 43% of the new HIV diagnoses. So you can clearly see that this is still a disease of disparities because our African American population for the US accounts for 33%, yet they are being affected by this disease at a larger proportion. Now, if you look at Kentucky, we do not mirror that statistic, but still there is a very significant representation here. And now, since now we know the burden of disease, both in the world, in the US, and in Kentucky, let's kind of look at transmission risk, because this is at the heart of deciding how you're going to address PrEP for patients, okay? So what is the estimated risk of HIV transmission per episode of vaginal receptive intercourse? Again, low tech, I'll take hands. Anyone think it's less than 0.5%? Okay, some hands. What about 1%? A few more hands. 3%? Okay. 5 and 10. Okay, so the actual answer is less than 0.5%. And again, I should clarify, this is per act, okay, per act. So very few people had their hands raised for that, but it is less than 0.5%. So let's look at the odds amongst all the different modes of transmission. So if you look at blood, so the big groups are blood-borne transmission, sexual transmission, and there are some others which is negligible, but they list it there because you get these questions in clinical practice. So if you look at blood-borne transfusion, blood transfusion will be the highest risk. Of course, we screen blood products, right? Now, if you look at percutaneous needle sticks, so your occupational exposures, we've all grown up, like, been educated on the notion, 0.3% for a needle stick, which is kind of that. This is a little bit more than 0.2, so you can round it up to 0.3. And if you look at sexual transmission, the highest risk is going to be receptive anal intercourse, and that's 1.4%. When you start going down here, it will be less than 0.5%. Okay, actually less than 0.1%. So let's go dig into what is the rationale for PrEP. Why do we talk about giving a drug to prevent HIV acquisition, right? So the first thing is there's no established cure or vaccine to prevent HIV. We've all kind of heard on the news about the Berlin patient and about the London patient. So these were patients who had HIV but also had a hematologic malignancy that required a bone marrow transplant. So these folks, their hem-onc docs said, okay, let's get a donor that has a deletion that prevents HIV from getting in the cell. And that's how those cures were achieved. So this is not a scalable solution. You can't do a bone marrow transplant for everybody. As far as vaccines, there had been lots of interest in trying to make a vaccine to prevent HIV. The problem is there's a lot of genetic variability in HIV, and they weren't able to find a good target. So those vaccine trials were not very successful. So we don't have a cure and we don't have a preventive vaccine. The second point to consider is I just walked you through the global burden of disease. So this is pretty big. And so if we don't have a cure and we don't have a vaccine, we need to focus our efforts on other things. So behavioral risk modification is one thing, educate as to modes of transmission, and medication prophylaxis. So that's where the rationale comes from. Now, we know this works because in animal studies, they did show some efficacy in using tenofovir alone or in combination with emtricitabine in preventing simian immune deficiency virus infections or a hybrid of simian and human immune deficiency viral infections in animals. And we also know from our experience in protecting infants that are exposed to HIV positive moms, right? So they're born to HIV positive moms, and also during breastfeeding. So we have that experience to back that up, okay? And this is the estimated number of adults that the CDC that says that would benefit from PrEP. So if you look amongst all the different groups, you're adding up a total of over 1 million people in the US who essentially are at a higher risk of HIV transmission, okay? So now, since I've walked you through burden of disease, the rationale, what is the data behind this? Does this really work? So I'm going to walk you through just some of the landmark studies. I can't go through all of them because there's too many. So let's start with a couple of these. So the first one I want to address is the HIV PrEP efficacy studies in the group of males who have sex with males. So this is a big study, landmark study. It's called the IPREX study. I kind of would have called it Prexy, but they thought IPREX sounded better. But this came out in 2010 in the New England Journal of Medicine. So this was a randomized, double-blind, placebo-controlled safety and efficacy trial in multiple centers across the world. And these were HIV-1 seronegative men or transgender women, but who had sex with males. And these folks all got monthly HIV testing, condoms, risk reduction counseling, STI management and screening, and they were randomized to either no medication or medication. And the primary endpoint was to look for seroconversion, right? So if you look at this, in the group that got the therapy, and this is tenofovir and emtricitabine, you had 1,250 patients, and similar number in placebo. The number of new infections in the arm that got the medicine was 48, and 83 in the placebo arm. So you saw about a 42% risk reduction here. Now, they did a post hoc analysis and kind of went to look at the folks who took the medication and had measured drug levels, and they saw that in the folks who actually had good drug levels, that risk reduction increased further to up to 92%. So that was the first big study that came out showing efficacy of this strategy. The next study I'm going to walk you through is the PROUD study. And this was a pragmatic open label trial. Does this approach work in the real world? Okay. And this was a study done in the UK, and that's why your randomized is spelled with an S there. So you had your intervention group, right, that was on the study drug, which was combination tenofovir emtricitabine. There were 268 folks in this arm, and they knew they were taking the drug because it was open label. They got their follow-ups for STI checks, they got counseling for every 3 months, and they were followed for a year. So this group actually got this was called the immediate PrEP group. They started out on the PrEP medication from the get-go, okay? In this group of the 268, about 13 people stopped taking their PrEP because of side effects, but 12 of 13 actually went back on it. And in this group, you have 3 out of 268 men acquiring HIV. And 2 of those 3, when they looked at it, had actually dropped out of the study. So they weren't really on the PrEP. And 1, they think, actually had HIV just before starting PrEP. So that was one arm, immediate PrEP. We start PrEP now. We do all the counseling. Let's see what happens. The other arm, there was about 255 men, And this was the delayed PrEP arm. Let's just do counseling and risk reduction and behavioral modifications, and then in 1 year they can start PrEP, right? So they did the same things as the other group. In this group, very early on, 20 out of the 255 men acquired HIV. So their goal here was to accrue at least 5,000 patients. So by 500 patients, they saw this big difference. And they're like, we're going to have to stop this early because this works. And we need to offer the PrEP to both arms. So that's what was done. And just as a summary, same things I kind of pointed out before. So this study had an 86% risk reduction. And this was a pamphlet in the UK that they were distributing, kind of showing that there was this protection offered. And the other point that they made was there was no significant difference in STIs among the MSM on PrEP and not on PrEP. So there was not a change in behavior. And we'll go into this a little bit more later in the talk. And this difference was not noted in the first study that I talked about either. All right, so now let's explore the efficacy studies in another group. So this is heterosexual men and women. Does this work in this group? So the study that came out was the Partners PrEP study, and this was published in 2012. This study was done in Africa, and you got over almost 5,000 serodiscordant heterosexual couples. So if the HIV negative partners, most of them were actually male. And I would like to point out that the positive partners, they were not on treatment for HIV. And you might say, what? They weren't on treatment? That's because the guidelines changed, right? So before, you didn't treat everybody. You waited till a certain cutoff of the CD4 count. So this was at the time where you were not treating everybody yet. So that's why they were not on treatment. And these folks were randomly assigned to either tenofovir alone, tenofovir in combination with emtricitabine, which is what the other two studies did, or placebo. So this is what they saw here. In the tenofovir alone arm, you had 17 new infections, which is about 1%. In the combination arm, you had 13 new infections. And look at placebo. You had 52 new infections in this group. So when you look at the risk reduction in each of the groups, definitely better than placebo. But when they looked at these two compared against each other, this was not a statistically significant difference, but both worked. All right, and then the last study I'm going to share with you is the other group, big group at risk, is injection drug users, right? So this was called the Bangkok study, and this was published in the Lancet in 2013. This was a randomized double-blind study, and they took over almost 2,500 participants from several drug treatment clinics in Thailand, and they assigned them to tenofovir or placebo arms. So here again, you see number of new infections less in the drug arm, and here was almost 49% risk reduction. So that's the data behind that gives us the basis for, does this treatment work? So we've seen that this does work. So now let's look through, how do I assess my patient, and how do I stratify my patient according to risk, right? So Jack is your patient, and he wants HIV PrEP, okay? So he's 28 years old, he's an MSM, and he's had 4 partners in the last year. He wants to know if he's a candidate for HIV PrEP. And I'm sure some of you have gotten these questions in clinical practice. So which of the following would place him at a higher risk for HIV transmission? Would it be if he had a HIV positive sexual partner? True, false? Nods, yes? Okay, so that's true. What about if he had an STD diagnosed 2 years ago? Does that put him at a higher risk now? What do you guys think? Yes? No? Some say yes. So I'll go into that. What about the 4 sexual partners in a 12-month period? Is that considered a high amount? So we'll go into that. It's subjective. I realize that. It's very subjective. What about inconsistent condom use? So that would be a yes. Okay, so let's go into this. How do I assess my sexual risk for my patient? So if they're monogamous, your concern is that partner HIV positive, right? Because if they're monogamous and their partner's HIV negative, you're not at a risk for HIV, right? And I'm talking about exclusively monogamous because, I've had patients like, yeah, I'm monogamous. I only have the 3 partners. So you have to explain that very well, what you're talking about. So if they're monogamous, but their partner is positive, you consider PrEP. Now, let's say they're not monogamous. What are the things I'm going to look for? Do they have anonymous partners? Then I consider PrEP. Do they engage in condomless penile anal or penile vaginal sex? I consider PrEP. If they've had, so this is the cutoff, I realize this is subjective, but if they've had more than 5 partners in 6 months, that's considered a high number of partners, and you consider PrEP. And if they're a commercial sex worker, you would consider PrEP. And the other part of the sexual risk assessment is the STI. So here for risk, you're looking more at the immediate 90 days. If they've had a recent STI in the last 90 days, you consider PrEP, okay? The other big group you consider is injection drug users, right? So if they have a HIV positive injecting partner, you consider PrEP. If they're sharing injection equipment, you consider PrEP. If they're injecting particularly heroin or cocaine, which has been associated with a high risk of HIV transmission, you consider PrEP. And even non-parenteral drug use, so what we call chemsex or particular meth, if you're using that during sex, that can decrease your likelihood of using condoms, so that would be another risk factor. So you can consider PrEP there. So that's how I assess the risk for my patient, okay? And this is just a summary of what we just said in table format. So who's clinically eligible for HIV PrEP? You've done the assessment, right? You've kind of like, okay, I should consider PrEP in this patient. So first and foremost, you need to document negative HIV tests prior to prescribing PrEP. Why is that? The medication we use for pre-exposure prophylaxis is 2 medications in 1. The treatments we usually use for HIV treatment usually have 3 drugs. So let's say this person seroconverts somewhere along the way, you only have them on 2 drugs, and that increases the risk for resistance, right? And this is a combination of medications we use pretty heavily to treat HIV as well. So you need to make sure at baseline and every 3 months that this person continues to be HIV negative. So that's the first big point. You should also screen for acute retroviral infection. So if they say, I had a new partner, now I have a fever, rash, swollen glands, your antennae are going to go up for acute retroviral infection. And then you have to remember to not only check your traditional serology, but also check your viral load, because that is how you're going to know if they have an acute HIV infection. So a good, thorough history and physical is important here. The next thing you're going to look for is normal renal function, because this medication you have to monitor because it can affect renal function. And the last thing you need to do is document the Hep B status, hepatitis B, or vaccination status. Why is that? Both drugs in this combination treat and suppress hepatitis B. So let's say you have the patients on PrEP and they're also Hep B positive. You're suppressing that hepatitis B. Now let's say their risk factor goes away. Now you're going to stop this, and then what can happen? You can have a flare-up of hepatitis B because you're taking away that suppressive medication. So this is important too, okay? And what about monitoring? So your monitoring at baseline will, in all your appointments, will include an HIV test. You're always counseling the patient about risk reduction. You are counseling them on adherence. We saw that this medicine works, but you have to take it, right? So that's important too. Assess for side effects. That's a reason why people might discontinue the medication, but you need to be on top of that. And STI symptom assessment and testing, and includes sites where they would be sexually active. Renal function is done at baseline every 3 months and every 6 months. And pregnancy test, if I put if uterus here because we do have trans patients and we do have, female to male trans patients as well. So remember that that's a possibility. How about the medication? So there's only one currently approved drug for pre-exposure prophylaxis. This was approved in 2012, and that's the combination of tenofovir, the older formulation, and emtricitabine, and that's what's called Truvada. Usually you do a prescription for 90 days until follow-up. We don't tend to give 11 refills on that just because you want to make sure they come back for monitoring, right? And there is a newer formulation of tenofovir that is being studied for PrEP with promising results. A big study just came out in one of the big ID conferences that was CROI, and it shows that this medication could also be effective, but not approved yet. And this newer formulation, the big plus is that it has less renal and bone toxicity. Okay, and we have ample experience in using this new formulation in HIV treatment because it's been out since 2015. It just hasn't been approved for PrEP just yet. All right, and what about when do you get protection, right? So, and these are very small studies looking at pharmacokinetics. So they saw that for receptive anal intercourse, you get steady state levels in the rectal mucosa by 7 days. But for cervical vaginal fluids, it takes a bit longer, and even steady state in the blood, it takes a little bit longer, about 20 days. So that's kind of the time frame that even the guidelines cite there. Okay, now we're going to go to a really interesting part, which is what are the barriers to prescribing PrEP? What are the concerns that providers have when they're going to do this? So let's go back to Jack because he's still asking about PrEP. So what are some of the initial concerns that a provider would have about starting PrEP for Jack? Would it be that, well, you could use condoms instead of PrEP? That might be a possibility. 2 is that, well, if I'm giving PrEP and they're less concerned about HIV, they might engage in behaviors that might increase their exposure to other sexually transmitted diseases. So that's a big concern, right? Another concern is, well, if they're not going to be adherent to their medications, then they will be at risk for resistance. And then eventually this medicine won't work at all. So that's another concern. And the other concern is to do with workflow. Will this overburden my workflow? Will I have to be sitting doing prior authorizations? Will I have to be, doing all this paperwork in order to get this approved? So that's a legitimate concern as well. And will follow-up visits, if I'm seeing these folks every 3 months, will that overwhelm my capacity? And the other issue is PrEP cost effective? Is it is it risk benefit cost effective? So those are some of the concerns that most people would have before they start this regimen. So let's look at each one of these. So the first one is condoms versus PrEP for HIV transmission prevention. So from older studies, we know that condoms are about 87 to 89% effective in risk of HIV transmission, and PrEP in the larger, in the more optimistic studies, up to 92%. So I would say these two things should go in conjunction, and again, assessing your patient risk, of course. So what about risk compensation in PrEP? I think that's probably the biggest concern most providers have. Are they going to now engage in riskier behaviors and get other STDs? So I'm going to give you an example of what a risk compensation would be. So I'm going to give you a very simple everyday life example. So let's say I have a meeting every Tuesday morning at 7 a.m., crack of dawn, okay? So when I wake up on Tuesday mornings, I'm not going to look at my Facebook and I'm not going to look at my email because that will put me at risk of getting to my meeting late, okay? So that's my risk homeostasis. I've evaluated my perceived risk for something, and I'm weighing what I'm willing and not willing to do, okay? So Tuesday morning, I'm not checking Facebook, I'm not checking my email because I don't want to get there late. Now, let's say somebody texts me the night before and says, hey, the meeting is at 8 a.m. tomorrow. So now guess what? I'm going to reset my risk set point, and I'm going to check my Facebook, and I'm going to check my email. And guess what? I might be putting myself at risk to getting there late. Now, if we translate this into the PrEP scenario, essentially John Doe is MSM. He's not willing to risk condomless sex because he's scared of HIV. Now I introduce PrEP, and now I reset John Doe's risk set point, and now maybe he will engage in anal condomless sex because there's something that decreases that perceived risk. So this is the whole concept of risk compensation, okay? And that I think is the main concern. So let's look at what other scenarios was this a concern? The first one I would say is female contraceptives, so our birth control pill. So when that first came out, there was a concern that it would promote riskier sexual behavior. The other scenario is needle exchange programs. There was a concern that if you're giving them clean needles, you are enabling and prolonging IV drug use. And even with the HPV vaccine, there was a concern that there would be an earlier sexual debut and a higher number of sexual partners. Well, none of these associations were actually proven, and that brings me to a very interesting article in the CID from 2013. If you have a chance, check this out. So this is all about parallels about the birth control pill and PrEP. So, they're kind of comparing the two and looking at when it came out, how many people were actually studied, the cost of this, and actually very interesting story behind birth control pills. So this was Margaret Sanger, who was the founder of Planned Parenthood, who came up with the concept of birth control. So she got a backer who had the money. They got a couple of docs here to work on the pill, and that's when the first birth control pill that came out. And this was their ad. That was Andromeda breaking out from her chains. So this whole thing was very taboo in the United States in the late 50s. So actually all the studies had to be done in different sites, so Puerto Rico and other sites, to actually get the data saying that this worked. And in the beginning, wasn't even approved for single women. It was only approved for married women. So we've come a long way, but I just thought this was a very interesting parallel. So let's look at what the studies showed as far as risk compensation with PrEP. Do people engage in riskier behaviors or not? So actually, several of the major PrEP trials did not demonstrate this risk compensation. Things tended to even out. And there were no increases in STIs from baseline noted. And in general, there were no differences in STI rates between the two groups. And one could argue, well, those were all done in study settings. They knew they were coming and being asked these questions, so could that have changed things? I think the PROUD study was more an open study, real life sort of thing, and they didn't see differences there either. So, all right, what about the concern with PrEP use and HIV resistance? So that also, there's two types of resistance. You can either acquire wild type virus, and then because you are on PrEP and not taking it right, the virus then becomes resistant. That's one possibility. Or the partner you got the HIV from already had a resistance virus. So those are the two types of resistance. Again, the studies did not show high levels of resistance. Couple of case reports, very low numbers in terms of resistance. So that does not seem to be a big issue with PrEP. What about workflow? So the appointments every 3 months, again, I would equate that to like any chronic disease you all manage. Most of our folk that I see in clinic don't have a whole lot of other comorbidities, so it doesn't seem to take up that much time. And when we talk about our experience, I'll tell you how we do it in our clinic. As far as cost effectiveness, the studies varied too much in models and scopes and timeframes, so it's hard to really get a good feel for that. But the net result is that it appeared to be cost effective, but the drug today is covered on most insurances. So this comes to our most interesting part, at least for me, because this is our experience. So let's go into that. So we started the PrEP clinic in October of 2017. And we do serve insured and uninsured patients. We have a small amount of grant funding from the Kentuckiana AIDS Alliance. So, we're not able to fund the whole treatment for everybody, but we are able to help patients out. And we've had a total of 101 patients that were initially referred for PrEP services. And these referrals come from different parts, health department, a lot of them, some of the syringe exchange programs, different places, primary care offices. So we have a very solid collaboration with our pharmacy team. Most of you know this, but even in our HIV experience, we have worked for 20 plus years with a steady collaboration with our pharmacy team. There are HIV specialty pharmacists that are available all the time for us. And so it made sense to just use that same model when we transition into PrEP. So our average medication copay is about that, $1.09. And the most common side effects reported were nausea and headache. And then these are our patient characteristics. So our mean age range 36. You can see most of our folks are males. When we look at the breakdown here by race, most of them white, but we have a 20% African American population and mostly non-Hispanic. And then we also looked at the number of patients with STIs in our population at baseline and during their stay in the program, right? So again, we did not see a big difference here. We had 10 patients out of the 67 that remained from the 101, and 9 patients during the program. So again, not a difference there. We have about 13% refugee patients. 4% are housing insecure. And as far as insurance, 80% of our patients have insurance and 20% uninsured. And even the folks that have insurance, if they have issues with copays or things like that, we're able to help them too. This is our main distribution of risk factors. So our 3 big groups are males who have sex with males, somebody who has an HIV positive partner, so they're monogamous or not, but they have an HIV positive partner. And the other big group is condomless sex. Some people will have multiple of these risk factors, but those are our 3 main groups. What about retention and care? So here, out of the 101 that were initially referred, we had 67 that actually made it to the first appointment, right? So that's 66%. Of those 67, 2 were already HIV positive at baseline. So that left us 65 patients. And of those 65 patients, 60 of them, so 92%, actually came beyond that first appointment. So they came to the first and the second appointment at least, okay? And when we look at the rate that fell out of care, when you look at this number, it looks pretty high, like 23 out of the 60 discontinued care, but we were actually able to look at what were the reasons for discontinuing care. So there's 11 that we simply could not track down. And again, our pharmacists, front desk, they actually call these folks who don't show 3 times. They don't find them, they send a letter. The front desk is calling. So it's like we attempted to reach them. Couldn't reach 11 of them. Of the other ones, 3 of them moved out of state, and they plan to continue PrEP when they moved. A couple of them stopped because their positive partner was actually undetectable. And we know from CDC guidance that for sexual transmission, they have told us undetectable equals untransmissible, and that's only for sexual transmission, not for any other transmission. So this was sort of a reasonable thought process in stopping PrEP for this patient. There were only 2 who stopped due to severe side effects. I showed you 9 and 4 that reported side effects, but only 2 actually had to stop the drug due to nausea, diarrhea, so 2 of them. Some of them decided not to start from the get-go. There were 2 younger patients that were on their parents' insurance and didn't want them to find out and decided not to do this. And then one person said, came to the first appointment, was like, nah, I'm worried about side effects, I'm not going to start. So these folks here didn't even start PrEP. And this one here said, you know what, I'm not sexually active now, so I really don't have a risk, so I'm going to stop. So if you weed out these guys here that never started, or that have sort of a legitimate reason, because PrEP is all about reassessing the risk every time you see them. This is not intended to be a permanent, you're going to be on PrEP forever. It's as long as your risk factor is there. So if you weed those out, our retention rate gets closer to 75, 78%. Okay. And so now let's return to our initial case. So Going to put this back on there. So this is Joe. He is 28 years old. Again, no past medical history, not on medications. He told you he's going on vacation. He's bisexual. He does not have consistent condom use, and he is planning to have a good time while abroad. So how do I assess Joe here? So first of all, I have to ask all those questions, right, that we talked about before. So is he monogamous? No, he's not monogamous. Does he have anonymous partners? No, but he does engage in condomless sex. So there I would consider PrEP, right? And these don't apply to him. He has not had a recent STI. But just here, you kind of have one indication that sort of puts him at a higher risk, right? And then you have to ask about injection drug use. He denies injection drug use, so that's not a concern for you, right? So if you look at this patient, he's asking about, I'm going to travel and I'm going to have a good time. Do I use PrEP? But if you do this assessment, even without the travel, this guy might be a candidate for PrEP, right? So for travel in particular, there's no consensus guidelines, and you have to take a risk assessment and individualized approach. If you were only concerned with travel in a patient, there are, folks that use this approach of starting the PrEP a couple of weeks prior to travel to achieve steady state. But this guy, if you actually truly did the assessment, he qualifies even without the travel. Okay, so that's how you would approach this patient, at doing your risk assessment and asking those questions. So in summary, despite advances in HIV treatment, it's still a disease that has great global burden, and it is a disease of disparities, as we saw. So understanding all the risk factors that place individuals at a higher risk is really essential for this. And this individualized approach of discussing PrEP, getting to know your patient and figuring out what their risk factor is. A lot of clinicians might be hesitant to ask a sexual health history, or are not comfortable with that, but that is something that helps assess the risk and could help your patient prevent HIV risk transmission. And then truly, I think it's a combination of everything. It's your risk reduction counseling plus condom use plus PrEP in whom it's indicated that is really going to decrease that transmission risk. And that's all I have for you. Open to questions. Mm-hmm. Oh, no, I meant they would take it inconsistently while they're on it, like, stretch the medication or. No, but that's the point. Like, even if you stop, or even in these studies where people dropped out or stopped, even with that, the rate of resistance was very negligible. Yeah. And what was the first question? Two drugs. Oh, okay. So the two drugs versus one. So the other big studies use the combination therapy. So that's probably why that was used. And in some of them, I didn't put the female trials up there because it was going to be too long, but some of them, they saw the combination therapy worked a little bit better. So it just, side effect profile is pretty similar. So, okay. Yes. Mm-hmm. Mm-hmm. So as far as the first question was, have they looked at HIV resistance in the IV drug use population? And they have. I don't have the numbers in, but it was still a low. And then that's a very good point regarding the African American women being a vulnerable group. And that holds true. It's both African American men who are MSM are probably the highest risk group. And then when you go down to the women, African American women are the highest group amongst the women. So definitely there should be strategies to assess that risk in those populations. They are our target populations to start with because they are our vulnerable populations. Yes. Yes. Mm-hmm. That's a great question. So there actually was a trial that looked at on-demand PrEP. It's called IPERGAY. It was a French study, and they looked at, okay, if you know you're going to be sexually active, you take 2 pills of the tenofovir emtricitabine 2 to 24 hours before you're going to be sexually active. Then 24 hours after that, you take 1 pill, and 48 hours after the first dose, you take the second pill. So it was like a loading dose and 2 more doses. And actually, that study showed 96% risk reduction, but when they went and looked at it more, these patients that were on the demand PrEP, they were taking up to close to 4 doses a week, which is what a daily PrEP person would normally take. So was it really the on-demand that worked versus they were almost on daily PrEP, you know? So definitely we are always going to counsel on take the medicine every day because we know that's how it works best. But there does seem to be a protective effect if you take up to 4 doses a week. So our thing is let's do the best we can to take this every day. You know, that's how we counsel our patients. Okay. Yes. Mm-hmm. Exactly, and truly that's an issue. And the seroconversions, the other one that I read about was a similar thing. They actually had detectable drug levels, but still seroconverted, right? So that's how you have to approach it. Exactly that way. Look, PrEP is not 100% effective. You still have a risk, but as opposed to nothing and no behavior risk modification, this is probably going to give you the protection that you need, but it's not 100%, and you might still seroconvert, and that's why we have to follow you every 3 months and check on you. So, as far as the expense, so as we said, the average copay was very low, and most drug plans actually have it covered. So we haven't had a lot of trouble. For our uninsured, so if you were to pay out of pocket, it comes out to $1,500 for a month's worth around there. But we've been fortunate in that most insurance plans have this covered. So as far as who pays for it, mostly insurance, and again, the out-of-pocket cost is not huge. Yes, yep, it's covered on that. Thank you. Thank you.